It's a great pleasure to introduce um, Dr. Sanjeeva Jeyaretna, a very good friend of mine based in Oxford. So we've crossed the English Channel now. And Sanjeev, although he works in Oxford, he partially lives in Cambridge, and we sometimes share our Cambridge laboratory. In fact, we have a session organized for in 2 weeks' time, but I believe he's ready, and he has very interesting program ready for us today. He will introduce us to it himself. Sanjeev.
Tom, thank you for the kind introduction. Right, so my talk is going to be a little bit different to everybody else. As you know, we're always trying to make the program better, and Emad and Vlad are very keen to try something different. And what we really want to do here is we want to make it very interactive. So I'm particularly keen that the 300-something people who are on Zoom join us. I'm going to ask the faculty to join in as well. I'll explain how that's going to work. And we're going to try and bring the people on YouTube, Neurosurgical TV, being broadcast in Japan and China along, but I know there's a bit of a delay. So this could be a little bit difficult to do that, but I'm going to try, okay? So
we have a little experiment here.
Indeed. Now, I need to advance my slide. Okay, so there are going to be questions as we go along. And what I'm going to need, and this is the first question, so we're going to start off nice and easy, but I want everybody to log in. Now, the key is don't lose your Zoom browser. That is the key bit, okay? So don't lose the Zoom browser. What I want you to do is to get an extra tab. I'm going to do it on my phone, and I want you to go to this web address, www.menti.com, and put in that code. So I'm going to do that on my phone. Can I ask the faculty to go in as well and go to that web address? And I'm going to ask everyone, don't lose your Zoom browser. Okay, I want you to, oh, some people are already on quickly. Everybody on Zoom, everybody on the YouTube channel, I know there's a delay there. Please log on to this one on a separate page, in a separate tab, on a separate device, and tell us where you're from. Now, are the faculty all logged in?
Yes.
Yeah. Dr. Gonzalez, good. Emad, are you on? I'm going to fill in the question as well. Now, given the hundreds of people who are joining this presentation, we're very keen to see hundreds of responses. I know there's a delay on YouTube and all of that. Roy, are all your residents logged in? Anybody have any questions from the faculty about how this works?
Oh, Asia is winning now.
Asia is winning.
Yeah, it's pressing a button.
It's one of those COVID steps.
Yes. Sorry, where do you click to?
So you're going to go to this website. Don't lose the Zoom browser. You're going to go to this website, and you're going to put in this code.
In fact, you have to use your phone or some other device.
Phone, or you open a new tab on one of your browsers. But if you have a phone, you're watching this on your computer, try on a different device.
So Asia is doing.
Come on, people from Europe. Asia is winning.
I know. What's going on? Sebastian, have you logged in?
No hope now.
I am logged in. I am logged in.
Vote, Sebastian, vote.
North America.
I think it's Asia against the rest of the world, yeah?
Okay, so we're getting up to 100 votes. So this is how it's going to work. We're going to have questions going forward. So we'd like to see everybody log in. I know there's a delay on YouTube and maybe a delay in China and Japan on Neurosurgical TV. But everybody on Zoom, there's 162 I see. Everybody on Zoom, get a separate browser, go on a separate device, and then I want you to vote. Okay? So this is how it's going to work. Good. All right, so stop it there. Yeah, Asia is in the lead. All right, excellent. So we're going to move forward. Oh, letting me move forward. Okay. Right. So I've picked 3 cases. We've had 4 days now of this seminar. So I've picked 3 cases. One is, I picked them for specific reasons. One is a case that's been a type of, a bit of anatomy that's been discussed in great detail. So let's see how much you've been taking in. One is to introduce a slightly different area of anatomy, just to bring that up briefly. And another one is just something I talked about before, and we've seen different ideas since then. So we'll talk about that as well. So that's the plan for today. We're going to have 3 cases that we go through, but people are going to vote, and you're going to tell me what you're going to do, what the anatomy is, and all of that. And let's see how we get on. Okay. So let's start with the posterior fossa mass. Okay. So 68-year-old gentleman. He comes in with progressive worsening of balance and gait and headaches. And these are his scans, all right? So I'm just going to talk you through the scans, obviously all axial cuts. This is a T2 scan showing that one there. This is a flare sequence, so you can see the mass suppresses on flare. And then we've got restricted diffusion here on the DWI scans, all right? So that's what we've got, the information you've got so far. So we're going to go to the first question. These are the options you're about to see, and I'm going to ask, what is the diagnosis? All right. So everybody, I'm going to vote. Everybody should be able to vote. Oh, we got an early win for epidermoid. Anybody else? Anybody else feel this is a cystic vestibular schwannoma? Anything else? Yeah, subependymoma coming up. Okay, we've got some epidermoid is winning hands down at the moment. So let's ask some of the panelists. Maybe Tom. You want to comment on those scans you saw earlier? What are your thoughts?
Yeah, so kind of the location and distribution and your strong suggestion of the restricted diffusion, although not the most typical I've seen, is consistent with epidermoid, but yeah, could potentially be other things as well.
Okay, so we also thought this was most like an epidermoid, so I agree. With the...
I have to add one more thing.
Yes, Imad,
a lesion, this sizable lesion in this age group, it by clinical appearance, clinical presentation disclose against malignant type of tumors.
Yes,
because he is not bad clinically in the sense.
Yes, that's right. He's pretty good.
So it's added to the diffusion issue.
Sorry, what was the comment on diffusion?
No, it adds to Tom's description that there is a restriction of diffusion, which is in support of epidermoid.
Yeah, I agree. And we also thought it was an epidermoid. Now, we've only got 120 people logged in of the 300 something. So I'd like to encourage all these people, all of you to log in, those 300 something people on Zoom, and everybody else in Asia, please do log in to this website. That is the code. We're very keen to hear from you on what you think is going on with these cases. So, okay, we believe this is an epidermoid. He's got significant mass effect, symptoms. So we have to try and decide what we're going to do. And of course, this is the neuroanatomy lecture. So we're very keen to first, well, we're considering surgery here. So the first thing, of course, is what is the location? So take your time, have a look at these pictures. Here, of course, is the mass again there. Here is a sagittal T1 with contrast, and you can see there's no real contrast enhancement in the mass, which would again be going with an epidermoid. So the question is going to be, what do you think? What is the location of this lesion? All right, and here are the options that I've given. Oh, CP angle, a close fight between CP angle and, oh no, sorry, Lushka is winning. Lushka's winning big. Okay, so while that's going on, I suppose the question about where this is relates to the surgery a little bit, doesn't it? Ek, you spoke earlier about this. What are your thoughts on it?
Yeah, I would have said from Lushka is rather similar to the case that I showed at the end. I think there's a portion that is protruding out into the lateral, junction of the medulla and the cerebellum, and there's a portion that reaches in medially. So it's sort of centered right at the outflow of fourth ventricle artery.
Yeah, okay. Anybody else have any views on this? Lushka is winning. Some people have said CP angle. Anyone else from the panel has a view on this? A different view than foramen of Lushka? No. Okay, so we're all fairly uniform on this. We can see that Lushka is winning hands down here nicely. It does have, of course, components of it within the fourth ventricle and the CP angle, doesn't it? All right, so we've sort of decided where this is, but there are some important points. It is, as we've described, a very sizable epidermal. I've just got some arrows here. I'll explain the first arrow. I just want to show that it goes up right to the 7th and 8th cranial nerves, as you'd expect of something coming out of the foramen of Luschka. And then you have to sort of understand if we're going to operate on this. We've worked out the location. It's at Luschka, so within the 4th and CP angle as well, as you'd expect. But then you have to start to work out what are these flow voids here. So they are clearly blood vessels, and they form an important part of the anatomy that you have to understand when you're going to operate on something like this. And Tom and Echo have been talking about this in the previous seminar and this one. So the next question, of course, is...
Can I ask a question to Sanjeeva?
Becky, yes.
The primary question is it intra-axial or extra-axial?
Ah, yes, that's a good point.
Very basic question.
Yes. Okay, Keki, what do you think? Intra or extra-axial?
It is intra-extra-axial.
Yeah, I think in general, epidermoid is a cisternal lesion. But there are intraventricular components, but it gives a different irritation system. But they are cisternal lesion in generally in that CP angle area. Okay. And it's easy to communicate through the Luschka.
Yes. Yes. Now, when you come to operate on it, though, Kiki, what do you think about it? It's a difference, isn't it, how you operate on intra and extra-axial lesion? The techniques are slightly different, aren't they, Kiki? What are your thoughts on that?
I think, if you ask me, this could be approached by just...
No, approach is later, Kiki. That's coming later.
Okay.
Discuss that at the moment. That's
what was your question?
So when there's intra-extra-axial, then the dissection techniques, are you purely arachnoidal? Are you working within?
Yeah, then I think, we just heard a very nice presentation, Tilo Wheeler.
That's again approaches, so we'll come to that later. Okay, well, maybe we'll come back to the discussion a bit later. Okay, so the lesion is filling, the fourth ventricle, but as we discussed, through Luschka and also in the CP angle. And before we decide how we're going to operate on this, and there are a number of different options you could consider, you have to understand a bit of the anatomy, don't we? And so the next question has to do with these two blood vessels, which are flow voids there. So the question is, and you've seen lots of talks about this, what structures are shown by the red arrow? So we're all going to vote. Pica's off to an early lead there. So let's see what people think. We got 6 people onto the ICA. And so this is in tumors in this location, particularly in that bit there in the fourth ventricle. Of course, the critical bit of anatomy to understand is the pica. And for some of these questions, there's no right or wrong answer here. There is a right answer. It is the pica, clearly, that we're seeing there. Okay, and we'll talk about the segments of the pica now. So this is in a minute. So the next question is, what approach will you employ? And Kiki mentioned one of the options, but I've given a number of different options there. So, we said it was a CP angle, what some people consider a retrosigmoid approach. We heard people discuss the transvermian. Would you go right through the cerebellum? Part of this, I think, depends on your skill level in what you're comfortable with doing. So I don't want to say there's a right or wrong approach. Of course, we would all favor approach. There's one approach that I favored, which I used in this case. All right, so this is interesting. We've got about 30 people saying retrosigmoid. Imad, you gave a nice talk on retrosigmoid last time. What are your thoughts on using the retrosigmoid approach for this case?
First, I go completely extra-axial.
I agree.
Since that lesion going around the entry area of the facial 8th nerve complex, I want to make sure I'm not working blind there. And the other things, I feel I'm a proponent, a supporter of the hybrid approach with the endoscope. So I can still use the endoscope from that area that coming more medially to take the last bit. Epidermoid, I used what it was mentioned for the chordoma, the application of chopstick technique here. In general, epidermoid is an avascular lesion. And the vessels inside, we call them the hanging vessels because they are not displaced but encased, but is easy to dissect from. So this is my choice. And there is always an option for a combination. I mean, you cannot be stick to one. Sometimes you find that angle is not adequate, but there is the wide base extension of that lesion along the posterior petrous, and I feel from the CP angle I have a good component to remove rather than to do anything through the cerebellum.
Okay, so you would favor the retrosigmoid approach. Okay, interesting. Now, Kawase, I'm sorry, and far lateral, I don't think these are particularly good options. The far lateral really is for something lower down, Kawase for much higher. So I'm sorry, I don't think those are particularly good approaches for this case. Of course, there may be differing opinions. We had a long discussion about going transvermian. You could even consider transcerebral. I think that really depends on your what you're comfortable doing. You have to do what's safe for the patient. As a skull-based surgeon, I really dislike breaching the cortex anyway. So I would be looking for one of those two approaches. Anybody who feels the telovela is a good approach from the panel?
Yeah, I would do a telovela.
Why is that, Ramesh? We just discussed how it's going to the CP angle.
Yeah, I know. But your one of the primary aims is to make sure that you don't injure the pica, which are quite medial and shifted to one side. And and also with the telovela approach, once you get a good elevation of the tonsil, you are able to follow this epidermoid into any crevices that it may follow. And all you need, and also you're not traversing any neural plane. You are within the tumor, and you can get with endoscope, additional endoscope to the lateral CP angle position. You can get extensive resection of all these tumors.
Yes, I agree, and that is the approach I chose. Actually, I went for, although I do a lot of retrosigmoids. For acoustics and things, actually, I went. Sorry, somebody's saying something.
Sanjeeva.
Yes, Vlad. Yes.
Yeah. There is a combination. I would do a far lateral or infralateral approach and then teloveral, unilateral teloveral. I would lift only the ipsilateral tonsil, and you get to the whole posterior part of the lesion. You get to the CP angle easily. You get easily to the fourth ventricle by this approach. Yes. Far lateral plus teloveral.
Okay,
but can I just make a comment, Sanjeeva?
Let's go back and look at the pictures while we're talking, yeah?
Yeah, Vlad, I mean, I know, why do you want to do a far lateral and do a lot of bony resection for the epidermoid? For the epidermoid, the decision's already been done. All you need to do is to go inside the tumor. And
not that much. I'm not talking about far lateral as it is described. I would do it like a enough lateral,
Oh, yeah, I got it.
Yeah, there's no condyle resection at all because you will do all your work above the condyle, so you do not need to resect it. Not much work.
Yeah. Well, I think this brings me nicely to my point that you should do what you feel comfortable, what is safe in your hands. So we've heard, some very experienced surgeons. So Imad has talked about coming retrosigmoid. Vlad is talking about doing a far lateral combined with telovela. I actually agree with Ramesh. That's what I did.
Can I join Sanjeev?
Yes.
I actually would probably, and most people as well would in practice do, very much do what Vladimir said. Yeah. Often we think of certain approaches in isolation, but you basically do enough approach to be able to gauge it. So you can do sort of not midline but off midline, but lateral enough to have enough lateral approach for the anterior part of the tumor and have complete control over it. I've done a few of those, and it was kind of combined, sort of off midline and lateral enough approach. So
yeah, no, I think it's very reasonable, and these are all very good suggestions. Unfortunately, because of this file limit on this website I'm using, I can't show you the video. But actually, you
can comment also.
View a CP angle through a telovela, as I'll show some.
I think Sebastian got some comment.
Sebastian,
do you hear me?
Yes, we can. Sebastian, go on.
Yes, I have to say that I think I would be also in favor of a far lateral, not with condyle drilling as it was said, but the advantage here with this kind of approach is to have the midline access, to have the telovela access, to have the retrosig access. the goal in a lesion like this is not to resect what's inside the epidermoid cyst. If it's not a recurrence, the goal is to try to resect the capsule. And that's the only way to cure those patients.
Yes.
And if I remember well, she's quite young, so it makes sense to try to achieve a complete resection, and for this to have multiple line of sight, multiple angle to dissect each cranial nerve, each vessels, and to remove the capsule from it is nice.
Yeah. So,
So
I have to interfere here a little bit.
no problem.
May I? May I?
Of course. That's the whole point of
I think the age of the patient, I think in his late 60, how old is he? This age group, I'm not going to take the capsule from that lesion completely. Okay. You will ask for trouble, especially seeing these voids as well. In general, epidermoid is nice to dissect, but when it comes to capsule, I don't reinforce it in this age group. They can live with the residual 13 years without any problems. And you can always operate second time on these people without any major problem. So I won't be very aggressive regarding the capsule. I resect whatever is easy in front of me to resect a capsule, but if it's adherent, I will leave it.
Yes, I think it's very adherent you should leave, and that's actually what I did here, although the vast majority of it came out.
Okay. But the age of the recurrence is dependent on the amount of capsule you remove.
Yes.
So I would not necessarily remove
the
capsule. But if you just empty the cyst with leaving the capsule like it is, it will not come back in 30 years. It will come back much earlier than this. I agree that you could go back with a simple approach, but so can lose.
I said to resect as much of the capsule that is easy to dissect. But if it's adherent, don't enforce it.
Yeah, so you can see here there's a number of different approaches, and I suspect we may be roughly talking about the same thing if we actually watched each other's videos. But what we're advocating is as extensive a resection as possible that is safe to do. And we've had two very senior surgeons suggest a sort of far lateral position, which will give you access around both sides of the tonsil, which is interesting. I actually went for a pure telovelar approach and had a sort of nice view of this. And just for our more junior colleagues who are joining us on this webinar, I'm just showing a view from the side of the brainstem and the cerebellum. And of course, these Roton pictures are all available online for free now, and I encourage you to view them. And we're going to start looking here at the anterolateral segments, but the important segments involved in resecting, particularly in the telovelar approach, is understanding how the pica comes around the tonsil, and then the tonsillomedullary and telovelar segments of the pica, which is shown here. And there's some important anatomy to understand if you're going to use a pure telovelar approach to resect this. But as you heard, there are a number of other options here. So just to orientate you, this is the foramen of Magendie. You're watching the pica come up, and then you have its medial and lateral branches. This is the tela choroidea. This is the tonsil being lifted up. So the first, and this is earlier you heard about sort of Birmingham Smith, which, as I said, the skull base surgeon I'm not in favor of, but I understand may be used sometimes, and we heard can be safe. But my next question is to some of our more junior colleagues. I know the senior panelists will clearly understand this anatomy very well, but to everyone, what is this area here that I'm pointing to with the yellow arrow? So, what is shown by the yellow arrow? Please. Lushka's off to an early win here. Anybody want to go for seventh nerve? Okay. Well, seventh nerve is close to the foramen of Lushka. I think you'd agree while the voting is going on, Sebastian and Emad, that we're essentially saying a similar things, that we would resect as much as is safely possible. We'd take as much capsule as we could get. Do you agree with that?
I think what maybe everyone from their point of view, but what kind of Vladimir started talking, and I joined in later on with him, it was that the more angle of view and comfortable work you have, particularly on the delicate structures, vascular structures in particular, the more safely you'll be able to resect. So that's why going kind of directly forward into the fourth ventricle, but also from more lateral, so as you can view all the structures more anteriorly to the brainstem, you know, it would be just helpful, and it's not such a big deal to achieve that.
Yeah. So you're quite right. This is, of course, the foramen of Lushka, and this is the point I think Ramesh made right at the beginning, which I agree with fully, is that when you start coagulating and cutting, and of course this is all very stretched, isn't it? You've got a very large tumor here. In some ways that makes it much easier for you. And we've used this approach a few times to really get nicely into the CP angle. And I said I really like the retrosigmoid far lateral. I use that a lot for meningiomas, vestibular schwannomas. But actually, as you start, particularly in large tumors, as you coagulate and you start cutting around, you can open it nicely into Lushka, and you have an absolutely fantastic view right up to the root entry zone of 7. Beyond that, of course, it is where you're limited by the nerves coming into the brainstem. But up to that point, even with some ependymomas, you get an absolutely fantastic view. But as you heard here, there's lots of different approaches that you could take to do this very safely and nicely. But one of them is a pure telovelar. And this is just another view, just to explain that, showing how you working. This is the velum here, telachoroidea, how you can get out nicely into the lateral recesses of the fourth ventricle just by following that out. Okay, and so I just want to reinforce that when you see these sort of pictures, you have to remember the anatomy of how you can follow outwards. You have to understand where the pica is. You have to understand where 7 and 8 are going to come, and what you can do via a telovelar approach. Now, I just have one last question, because the other thing to remember, of course, is not just 7 and 8 and things that you can injure. There are other structures that theoretically you can harm, and I'm going to ask what is highlighted here in yellow. So we're looking from the back to show you again. You got the tonsil, pica, velum is here. This is the top of the tonsil with some of the pica vessels there. Vessels coming off the SCA from the top of the cerebellum, coming to supply this structure. And this is another structure. You have to be careful as you're working out into Lushka not to injure. And also relates to some of the things we discussed earlier. So what is the highlighted structure, please? Oh, people are rushing off with the dentate nucleus. Anybody have any other? Yeah, we've got some of the peduncle. Any other advances on the dentate nucleus? Well, in the interest of time, that's very good. I'm going to move forward. That is the correct answer. We're looking at the dentate nucleus there. Okay, good. So, these are just the post-op scans just to show the craniotomy here. You got a very nice resection with almost nothing that you can see on the post-op MRI scan. I knew, of course, that I left very tiny bits where it was very stuck down. But actually, the vast majority can be resected very nicely through this approach or something like that. Sorry?
Just one brief comment.
Yes.
One brief comment is that a lot depends upon what approach you will take. The bone work will depend upon what approach you take. And therefore, it's very important to be clear in your mind what approach you want to take, because you can't switch from a far lateral to a telovelar and vice versa. And
the position will be different as well.
And Sanjeeva, I think that goes to show with the epidermoid, even if you go minimalistic approach, rather trying to do a big approach, you can remove most of it. And that's Imad said, elderly patients, I wouldn't try to take the capsule off the lower cranial nerves.
Yes, I think it comes off easily. But I agree. No, it's very, very stuck down. This one actually.
I have one comment on the images. I think because I reviewed that subject, and I'm sure you all of you reviewed this subject, comparison of results cannot be done without having diffusion images post-op.
No, you're correct. You must have the diffusion images.
Otherwise, many people, they have claimed in the old publication complete resection and without diffusion images. Without diffusion images, you cannot claim complete resection.
So actually,
the important point.
I think there's an more important point here, Imad, that, so for example, I think this may have been reported, I can bring up the diffusion images. I think it may have been reported as a complete resection based on diffusion, but actually the resolution of diffusion is not that good. So I knew I had left very tiny bits were left behind in this case, but it was below the resolution of diffusion imaging, which is not as high as some of the other ones. But I agree with you. I should put a diffusion picture in here.
No, I'm not criticizing you because you put T2. I'm just saying in publication, people want to compare their results and claim complete resection. They have to show diffusion image to have a same currency for comparison.
I agree. But you can see that, mass effect and all of that is gone. But you're absolutely right. Diffusion is the most sensitive bit. And
I would have one comment too. There is usually not only one approach to the lesions. So if someone would choose retrosig, it's okay as long as far as the job was done. If you do the trans telomerer, that's okay. So this is about the approach. Whoever chooses the one with which he is most comfortable and able to do the job is just all right.
I agree 100% with that.
I think this is the message we have to give to the young neurosurgeons. They should not stick to one, and there are different good approaches to that lesion, and there is nothing wrong by having more than one approach to one lesion.
Yes, absolutely.
You cannot single it out by having everything all inclusive and by one lesion, one approach.
Absolutely, I agree. And then you should be able to do all of them and pick what is best.
But also one sort of overriding theme as well is don't restrict yourself too much too early unless you absolutely know that you can manage from the restricted approach. So
yes,
don't be a hero too early, or try to see that you can do something with closed eyes and with one eye and things like that.
Yeah, absolutely. Okay, let's move on to the next one. So there's a retired nurse. She has some numbness, mainly in the V2 distribution. She's got a history of previous Hodgkin's lymphoma, and she's got a right-sided mass in the sinuses. All right, so this is the mass here. So you've got a T1 image here. This is fat SAT, obviously, post-GAD lesion. This obviously is the maxillary sinus in the front there. So the first question I have for everybody is, where is this mass? Do you think it's infratemporal fossa, nasopharynx, orbit, pterygopalatine fossa, or temporal lobe?
You couldn't show us that picture again, would you, Sanjeeva?
Sorry. This is the mass. Okay.
Thanks.
I'll have a good look. I'm only giving axials. And I would like to know where you think mass is.
What do you think it is?
Okay. Good. Well, I'll just let that get up to about 100 people, and then I'll. Good. So I agree. I agree with the pterygopalatine fossa. I don't agree that's the infratemporal fossa, but if anybody wants to disagree, they're welcome to say. But let me just show you on the CT scan. Obviously, it's a bit hard. You only had one view, so it wasn't that easy for you to tell. We're going to discuss the borders and anatomy, so I'm not going to go into that too much, just in a minute, the pterygopalatine fossa. But if I just show you the anatomy on the normal side, show you where Vidian is, I think having the maxilla is very useful. This is where obviously where the tumor is on the other side. You've got pterygomaxillary fissure there. I think you'd all agree that the best place or the best way to describe the location of this tumor would be pterygopalatine fossa. Okay, so I'm going to move forward. So now I just want to introduce a little bit of new anatomy that we didn't cover, just to give you something new on the webinars. Now here, obviously, you can choose more than one answer. So this is different to the other ones. Okay, here you can choose more than one answer. So choose as many answers as you want. And I want to know, what are the borders of the pterygopalatine fossa? Okay, so please choose as many answers. I'm also going to answer. So please choose as many answers as you like for this And I think it's an interesting space anatomically just to discuss and talk again about the approaches. Good, so we've got, everybody's getting the palatine bone, which is correct. That's well done. That obviously forms the medial border. Okay, I'll just, maybe I'll let another get up to about 120 and then anybody else wants to answer? I hope our colleagues on YouTube are able to join us. I know there's a lag for them, so I'll just linger a little bit on this slide to see if our YouTube colleagues can also join in, and then we'll move on. Okay, I think that's pretty good. Right, so I agree. You've quite rightly identified the borders of the pterygopalatine fossa. You have the sphenoid bone, the palatine bone, the maxilla, and the pterygomaxillary fissure are the correct answers for the borders. Okay, I showed earlier where the pterygomaxillary fissure was. You have the sphenoid superiorly and posteriorly. You've got the descending plate of the palatine bone, and of course the maxilla forms the anterior wall of the pterygopalatine fossa. All right, and then the important thing to understand, of course, is that the arteries are in front, the blood vessel, sorry, the nerves are at the back. So let's look at the pterygopalatine fossa a little bit more on one or two of the important points. The other important points, of course, to point out are the middle terminates and inferior terminates and their relationship to pterygopalatine fossa. Okay, so the next question is, what arteries are within the pterygopalatine fossa? Again, you can put as many answers as you feel are appropriate. Please put as many answers as you think are appropriate. Maybe I'll ask one of my colleagues who probably do quite a bit of endoscopy. Miguel or Sebastian, you want to make a comment on this?
If Miguel not there, I think Igor gave a nice presentation on vessels yesterday.
Igor, excellent. Igor, come on. And what are your thoughts about the answers, Igor? No, we haven't got Igor. No problem.
I'm sorry, Sanjeeva.
Igor, excellent.
I was concentrated on something else. I apologize.
No problem. Igor, we are talking about arteries within the pterygopalatine fossa. And everybody agrees the maxillary artery is within the pterygo, which is of course correct. As neurosurgeons, we are very familiar with the sphenopalatine artery, which is also correct. It is within the pterygopalatine fossa. That is correct. What are your thoughts about the pharyngeal, vidian, and rotundum?
I'm not really
question. It's more really in the realm of ENT. So, but I think you're quite correct in saying that actually all of these arteries are within the pterygopalatine fossa. So this is a little bit of a trick question. So I'm sorry, it's a bit unfair, but these are all blood vessels or branches of the maxillary artery that are within the pterygopalatine fossa. And I see in response to that, everybody's adding a few more answers there to the other ones, so that's good. But yeah, all of these, so everybody got the maxillary artery, and a lot of people also understood the sphenopalatine that we all understand as neurosurgeons, but actually there are 7 openings in the pterygopalatine fossa. This, as you know, this is an inverted pyramid, and all of those things that I listed there are all arteries within pterygopalatine. So you get the maxillary coming in, and basically anywhere where you have a foramen, there is an artery going into it. So there'll be the sphenopalatine. There is a vidian artery, pharyngeal arteries at the back. It's not shown here. There will be an artery going to foramen rotundum. There will be an artery going up the infraorbital artery along with the infraorbital nerve, and of course the descending palatine. So actually the simple answer here is wherever you have a foramen or a nerve, there's usually an artery associated with it in the pterygopalatine fossa. Okay, so all of those answers were correct on that one. All right, so now we understand a little bit about it. The next question, of course, is how are you going to get to this mass in the pterygopalatine fossa. Early jump for the endoscopic approach here. Now, who's still here? What about Roy? You want to make a comment, Roy? Let's see who's still here on this. What are your thoughts, Roy, on... Oh, no, you're too far away. You got to come to the mic. Okay, I'm sorry. I should have won. Oh, okay, some people are going for orbiter zygomatic. That's interesting. What are your thoughts, Roy, on this?
Well, the endoscopic is the most elegant way to...
You have to speak up a bit more, Roy.
Well, the endoscopic approach would be the most elegant way to do it, but that doesn't mean you can't do one of the basic approaches on this. The cranial approaches are not really relevant. I would surely do an endoscopic approach.
Yeah, I agree. Anyone else have any thoughts on this? I like the one person who said radiotherapy. Very good. Any other thoughts?
Well, I mean, Sanjeeva, I agree with Roy. I think this is just behind the maxillary antrum, and the pterygopalatine fossa, as you know, is easily accessible through an endoscopic approach. And when we do a trans-pterygoid approach for skull-based lesion, this is a common location we encounter. So I think any lesion can be approached very elegantly through an endoscopic approach.
Yeah, I agree fully. Now, it looks like we have some ENT colleagues here. So the Cadwell-Luck, just for anybody who doesn't know what that is as it says here, radical antrostomy. That's where you're coming straight through the back of the maxilla, which takes you nicely into the maxillary sinus and will take you straight through the back wall, will take you to pterygopalatine fossa. Yeah. But I agree fully. I think this is the preferred approach. You can get almost anywhere with the pterional, really, but it's this unnecessarily destructive pterional orbital, anything like that. Equally nowadays for a Cadwell-Luck, although it used to be the standard way to get to this place.
Anna Lucia is asking, what would you do if you don't have access to an endoscope in your center?
Oh dear. Well, there are a number of options. You can refer the patient. Because if you look at it, it's quite a small tumor, isn't it? So to do a very destructive, sorry, I'm trying to move backwards. To do something quite destructive for this tumor, I think would be unnecessary, really. And you could consider referring somewhere else. There are, of course, approaches you can do, open approaches in infratemporal fossa and pterygopalatine fossa. But I think
in that case, I would just, if you don't have access to endoscopic surgery, just go back to what we were doing before the endoscope came into play.
Yeah, your ENT surgeons will be able to do a Cadwell-Luck.
Yeah, so that
can be done open.
Open the gingival incision, get into the maxilla, go to the posterior bottom of the maxilla, and you're there. So it is a very good approach, and it heals pretty well. So there's no facial scars either. So it is possible. Yeah.
I think the risks are slightly higher, to things like the infraorbital nerve, but yeah, very reasonable. But as we discussed, endoscopic approach is beautiful through here. You open up into the open the uncinate, open the bulla ethmoidale. If you want, you can open into the anterior and posterior ethmoids, and then you're in nicely.
I think, as Sanjeeva is saying and defending the intranasal approach, with endoscope you're going to have a smaller hole, but there was a life before endoscope, and you could actually make the hole bigger and work through it without an endoscope. So maxilla is actually a fantastic. It's a bit like transphenoidal approach to sella and so on. The maxilla is a tremendous sinus to approach the pterygopalatine fossa too.
Yeah. Not unreasonable, though we get an absolutely fantastic view nowadays coming
Pablo,
that way.
This is Moody.
Sorry?
Pablo, this is Moody.
Moody.
You and I have...
I'm Moody.
You and I have both worked in Zanzibar, and we have a microscope there. If you don't have an endoscope, a Cadwell-Luck is just fine. You can just make an incision on the gingiva and get in there. And if you go to the image that was showing the tumor, just go back, Sanjeeva.
Yeah.
There you go. No, the mass lesion. If you look at that maxilla, you're straight in there into the tumor, and the incision for the Calvert Luck is not more than 1.5 centimeters above you so you can pretty much get there with a microscope and get to it. So I think the folks who asked, if you don't have an endoscope, what would you do? If you've got a microscope there, or you can get in there and have a look and get that tumor out.
Thank you. Thank you.
Okay. Anything else about this one? So,
Sanjeeva, I may have missed your comment about the diagnosis. What was the pathology?
Oh, I never said. We thought it was a schwannoma, but it came back as a malignant peripheral nerve sheath tumor, which was interesting.
Okay. All right. Yeah.
Right. Next chap, 59-year-old, getting progressive worsening of gait, some difficulty swallowing, actually comes in with hydrocephalus and some confusion and drowsiness. And this is the scan. Okay. Right. So obviously, we thought this was a petroclival meningioma. It's a true petroclival. It's medial to the trigeminal nerves. It's coming down on the clivus. But actually, the bits I want to talk about a little bit, we'll talk about petroclival, but I want to talk a little bit is the fact that it's actually also quite high. It went all the way anteriorly to sort of near the uncus. So high and anterior, and also coming all the way down. So we put an external ventricular drain in, obviously as the first step, but then we wanted to deal with the main problem. Right, well, this is now ripe for discussion. What approach? Retrosig, okay.
Well, you haven't put one of the most important approaches in your options, though.
Which is?
It is the supra-infra.
Oh, sorry. That's what I mean by transpetrous transtentorial, where you cut the tentorium and go in middle fossa and posterior fossa.
Why is it called transpetrous then?
Because you're taking the posterior petersectomy, aren't you? Or you combine
No. They're talking about the supracerebellar infratentorial approach.
Oh, supracerebellar infratentorial approach. Oh, interesting. Oh, I didn't.
He meant, I think, a lateral supra-infra.
Yes. Extreme lateral supra-infra.
This is what I call it Dr. Benish.
Exactly.
Approach.
Oh, this is getting very interesting. Okay.
I know that Vladimir liked this approach.
Right. Okay. Well, this is getting very interesting. You're right. No, I didn't. It's not something I used. I didn't consider that. Okay. Right. Who's in the? Anybody on the panel? Well, Ipe, are you on this call? You have an interesting approach to these, don't you? Is Ipe on the call? No. We haven't got Ipe here. All right. Anybody on the panel would like to go retrosigmoid for this lesion?
Well, essentially the supra-infra, that is supracerebellar infratentorial approach, is an extension of the retrosigmoid. So if you can expose the transverse sigmoid junction and work above the 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 tentorial surface of the cerebellum and use the retrosigmoid superior to the seventh nerve, that's the supra-infra extreme lateral. So yes, that's a great approach.
And would you do a middle fossa craniotomy as well, or you're just...
Not at all. I would cut the tentorium and look above.
And do you feel you go all the way anteriorly?
Oh, yes, absolutely. You can go, well, if there is tumor on the other side of the clivus, that means the lateral end of the clivus, maybe it will get to be difficult. But with endoscopes, you could solve that issue as well.
I think this approach, I like it, but for that lesion, if you put the X-ray again, please. You see the lower pole of that lesion is very low.
Yes, that's essentially the limitation of the supra-infra.
Yeah, this is the limitation. If it's a little bit higher, might be a consideration, but here you have to retract the cerebellum further down to reach the lower pole of that lesion.
That's why the retrosigmoid window is also used. So lesions up to the seventh nerve, eighth nerve is very easily done. Anything below that, you will have to extend further the retrosigmoid craniotomy to get access to that. And that part is difficult, I agree. But then it does not mean you have to stop with just that. That part can be accessed through another, an extension of the same approach.
Your axial view, can I have it again, the axial view?
Yeah.
The axial view showed that the amount of the lesion leaping in the subtemporal area, perhaps you didn't go further higher, yeah?
No, this is at the sort of level of 5, isn't it? This goes much higher. So it goes very high.
Much higher, yeah. It's much higher. If it's only this is component, I will go for retrosigmoid and supported with endoscopy, incising the tentorium from below. This is an approach published in 1992 by Dr. Amirati and Dr. Sami, where they go from suprameatal, resect most of the tumor, and then they incise the tentorium from below to retrieve the upper one. In the recent year, we did few of these cases complemented with the endoscope, 30-degree, to retrieve the amount up. But this amount up is very huge. It's not a small one.
It is very huge. Yes.
And we have to look to the blood supply of this lesion. The Casinari vessel usually is one of the major supply. If you want to take care of that one with less bleeding, you have to close that vessel at the tentorium edge. And I don't want to say what I have in my mind because you are still waiting for the vote. Once the vote is finished, and then I say what I said.
Let's get another view. Sebastian still on this call, or is he gone?
I mean,
what would you do, Sebastian? This is the tumor. What's your approach? Hello? I think you're muted. Are you? We can't hear you, Sebastian. You know you're there.
Hello.
We lost him. Victor, did you have something to say?
Yeah, I think a combined approach is much better. For example, simple mastoidectomy, presigmoid approach, transtentorial, transpetrous. I think in this kind of approach, you can go to most of the tumor.
Yeah.
I think this is my favorite approach, the combined approach, the presigmoid approach. And especially in that case, you said the hydrocephalus, this need an EBD because we want to elevate the temporal lobe on the left side. So vena blave, we have to be respected. But this is, I think, the approach that will hit the tumor from different angle.
Yes.
Yes, agree.
Now, can we hear back from Sebastian? No, he's gone. Is he? We've lost him. Ji Tang, you've unmuted. What do you think?
I think for this case, just I have taught today, and for I combine, I agree with the two simple ways to resect this tumor. Two simple means one is the subtemporal, and with the retrosigmoid approach. So
but subtemporal, G, how low can you go with the subtemporal?
Subtemporal approach for this lesion, we can reach at the level at the trigeminal nerve. Okay, it will remove part of the tumor, the microcave. We open the microcave, we can reach lower than the part of the trigeminal nerve. And for the part below the trigeminal nerve, maybe we drill a little bit of the petrous apex, just I showed in my video. And also we can reach the level about the abducens nerve. And for the lower part,
goes down to the lower cranial nerves.
We can use the retrosigmoid approach to remove either the lower part of the tumor and also the part lateral to the internal acoustic meator. For your case here, the lateral part to the internal acoustic meator is very difficult to remove through the subtemporal approach, even with the drill of the apex. So for this case, now I prefer to use the two simple, combine subtemporal with retrosigmoid approach.
Okay, okay. That's interesting. Okay, so the votes are in. So Imad, tell us, what would you have gone for?
I will go for the presigmoid approach without any hesitancy because this lesion is going beyond the level of the facial canal so it goes down. I need an axis down, and it goes high up in the subtemporal area. Is not a small component. And I need to tackle that dura because most of the supply comes from this dura. So I will win the two situation. The only backdrop of this procedure is the time consumption.
Yes.
You need to do a lot of drilling. But again, this is the principle of skull base we used to apply. Take more bone for the sake of less retraction, because any approach for this sizable tumor will be entailing a lot of retraction, and you need to have that wider exposure. This is what I feel about it. So that's specific lesion.
I agree. So as we discussed, I mean, it's interesting what G said. I mean, I feel any sort of fetus apex or temporal approaches, for me anyway, it's very hard to get below the level of the IAM. And retrosigmoid, of course, fantastic approach, but it's given how medial this comes, I really favor this sort of pre-sigmoid and middle fossa craniotomy in cutting the tentorium for the reasons Emad has said nicely. You get to the blood supply, less retraction, you're coming around the front, it gives you a nice window upwards. But what about nobody mentioned really the end.
Let me.
Sorry, who was that?
During many years when I'm doctor, when Amirati and Majid Sami described the presigmoidal approach, at that time I was very enthusiastic with the presigmoidal approach, and I did. And in some cases, transpetrosal approach also. But after all that experience, I came back to the retrosigmoidal approach, sometimes with, as our Chinese colleague has said, maybe with the combined approaches is necessary. Sometimes it's not necessary because you can even, in some cases, in the upper part of the tumor, just to drill in the petrous bone and you can go and remove that tumor. So this is my opinion. So I start at the time of the anatomy description or transpetrosal in some cases. And the last years I came back to the traditional
retrosigmoid. Now, nobody really talked about the endoscopic approach, which I don't think is a good one for this.
I did mention to you the joint venture but that sizable tumor up, that's what deprived me from using this one. A retromastoid with the incision of the tent from below and use the 30-degree endoscope to look up.
Well, I'm talking about coming straight through the clivus anteriorly, which I think is a very bad idea for this tumor. But let's just ask the question. Let's say, it was didn't go so high. But there are lateral restrictions, I think, but I'd be keen to hear what everybody else thinks. I think there are lateral restrictions. So then my next question for the quiz is, what are the limitations laterally in the endonasal approach? And what is the main one, maybe, I should say. Let's see what people think, whether they agree or not. Basilar artery, that's interesting, okay. Yeah, the lower cranial nerves, all right. What do people think about this? Okay, so it's quite a bit of the votes are in here. Sebastian, I see you're back. Okay, what are your thoughts on this, Sebastian?
Sorry, I had some connection issues.
No problem. What do you think about the lateral limitations to tumors in the midlines of the clivus using an endoscope?
For endoscopic endonasal, everything that is lateral is a limitation. Huh? So
what structure?
Nerve, inferior petrosal sinus, 7 on 8, 6 nerve. I think it's a bad, but I think you have the same opinions than me. It's not a good approach for endoscopic endonasal. It's a lateral lesion, petroclival. By definition, it arises from the petroclival region or tip of the petrous apex. So you will have a CSF leak for sure. If the idea is just to debulk the lesion, most likely you will not succeed and have some CSF leak. So the tumor problem will not be solved. And in addition to that, you have a 20% CSF leak. I think endoscopic is nice, in my opinion, in my experience, is nice for pure clival lesions, which are not so often. It's very rare compared to petroclival, but I did a few. And for those, endoscopic is nice because you don't have to deal with the lateral limits you're talking about.
Yeah, and I agree. And what does the panel think about debulking? Because these are tough tumors. They're not going to collapse down, aren't they? So like you said, debulking is a bad idea, isn't it? Does everybody agree with that? What do the others think about this debulking issue?
Debulking, not form meningioma.
Yes. These are tough tumors. They don't collapse down. It's a very bad idea. Right, I think we're running short on time, but I just wanted to highlight some of the points that we've just discussed there. That, you know, this would be a very bad approach for this sort of tumor. We talked about how the sixth nerve, low cranial nerves, but I also find it difficult dealing anything coming lateral to the intradural and lateral to the inferior petrosal sinus. I find that difficult. It's an interesting bit of anatomy. You can see how the sixth nerve goes through it. So you can see how in inferior petrosal sinus sampling for some pituitary tumors, you can very, very rarely see sixth nerve palsy, and that's the anatomy that explains that. Okay, I think in the interest of time, I'll go a bit quick. I went for a combined middle fossa and pre-sigmoid approach. You can then decide if you're just going to drill the retrofacial air cells and air cells here and keep the labyrinth or take the labyrinth, or if you're coming, you know, for the ascending carotid, whether you're even going to go transotic. This question now is, what is this structure here that you have to preserve in this approach? So what is the structure shown there? I think in the interest of time, we won't waste. Sorry? Did you say something, Roy?
No. I was just saying hello to Lorenzo, who just joined us here.
Yeah, quite rightly, it's the descending portion of the facial nerve. So that's absolutely right. You have the second genu and the facial nerve going down the stylomastoid foramen. Okay, and then we talked about sectioning the tentorium. I won't go through that again, but I'll just ask quickly, and we've discussed some of this. You can put as many answers as you like here. What are the advantages of cutting the tentorium? Put as many answers as you like. So I know at least 3 of us here like this. Oh no, Victor, you as well. At least 4 of us here like this approach. Anybody want to comment on what they feel? I know we've already discussed some of these things. What do they feel the big advantage are of this combined middle fossa and pre-sigmoid approach where you cut the tentorium for these tumors?
Isn't it part of the approach? You always cut it, right?
The tentorium, yeah, always cut the tentorium.
Yes.
And what's the big advantage of cutting the tentorium? In fact, you can do more than cut. You can actually excise part of the tentorium. I know Sebastian likes to do that. I like to coagulate it down. Emad?
Excise.
Yeah, you excised it.
In my opinion, sorry, Emad. Go ahead, Emad.
No, go ahead.
I am one of the main advantage, in fact, in my opinion, is missing here. Is it's that if you cut the tent, you can unlock the junction transverse sinus, sigmoid sinus, and you can retract it posteriorly and inferiorly, because this approach is based on this upward corridor below the temporal lobe. And you can only do that if you transpose the sinus. And to transpose the sinus, you have to unlock it from the tent. Then everything you said after the devascularization, resection of the tent, which is in fact the dural base, is extremely important and increase the view. But what increase more the view is that you can transpose the sinus posteriorly and use this space between temporal lobe and cerebellum.
Yes. I think I sort of talking about that.
To add to this one for the young neurosurgeons, this is very important when you plan this procedure to make sure there is no extreme lateralization of the sinus. And this is what they call it, the Trotman triangle. So you have to make sure that you have this triangle to drill out, and so you be pre-sigmoid. The other things, people not skeletonize the sigmoid down almost to the jugular bulb, they won't be able to mobilize the sinus medially, as suggested and nicely said by Sebastian.
Yes, that's right. Drilling, and in fact, you can even drill medial to the jugular bulb to give it just a little bit more space for your dural opening. So that's a very good point. Now, the one I don't agree, and people can disagree with me here. I actually don't think these are advantages of the approach. I agree, you get this fantastic working angle above and below 5, and you certainly devascularize the tentorial supply. But I actually think I worded this quite carefully. I said increased working angle above and below 9 and 10. Your view below 9 and 10 is very bad, actually, in this approach compared to a retrosigmoid, for example, because the jugular bulb is in your way.
That's why,
Sanjeeva.
Yep.
That's why the original, sorry.
So I think this is a great discussion, especially between the more advanced specialists, but for the younger, less experienced surgeon who just starts skull base or hasn't done the fellowship in a top place, I think G's approach is actually very reasonable. Combine a suboccip and get in from the front somehow through a subtemporal or even a extended terional approach. Some form of simple, doesn't require that amount of drilling, preserves the hearing. You make it away with less invasiveness, and these are the workhorses of your two approaches to the same location. So I would not necessarily say you end up with the perfect approach, but it's a very safe approach, and you will get most of this tumor out. So I think that should be one of the things we should give out as a recommendation. Safe is always what trumps the most.
Yeah, no, absolutely. And I think it's a theme throughout the talk that you have to do what is safe in your hands with your team. But just point out that that's not an advantage, and you can't get below it. And you do not get to the clival blood supply early. You get to it at the end.
May I add one thing for your comment about the lower cranial nerve? You are right. The original description of Hakuba approach, he complemented with retrosigmoid craniotomy.
Yes.
So we do the pre-sigmoid with the retrosigmoid, so you can access the lower part and guarantee the integrity of the lower cranial nerve if this approach was not adequate.
Yes, I agree.
I may just add one thing. The retrosig, in fact, for a combined petrosal is absolutely necessary, because if you don't do a retrosig exposure, you cannot transpose the sinus. So with retrosig, you have the advantage first.
Yes.
You can get CSF very early. This is something I do. I start with a retrosig incision to get CSF from the 9, 10, 11 cistern, and then, as Imad said, you can go to the lower aspect of the clivus, and you can transpose.
Yes.
The other thing is for Eckhart, I know we like to show the simple things, but they have to understand such a tumor with this sizable tumor is not for beginner. They have to understand, they have to work on the supervision and learn the technique. This is a benign lesion, and the best outcome will be with the best approach. We should not compromise on the approach because it's difficult for the trainees, but it's the best for the patient.
Yes, absolutely. Okay, I think it's for too long. I hope you found it helpful. Sorry, who was that?
I think that you could have a wide view, not only in the answers we can see in the panel, but also if you could the tentorium, you are going to respect the fourth cranial nerves and also the vascular and in the crural and ambient cisterns. You are going to get more control, distal control of these arteries, and they are going to send you to a most sure approach, a most sure decompression of tumor.
Yes, absolutely. Okay, and this was just to show the big angles on either side of the trigeminal nerve, and here to show that most I left some tumor onto the clivus here, but to show you get very high, all of that comes out. This is PCA coming off, so you get very high nicely. Obviously, you get the lower bits as well. Okay, I think it's gone on long enough. I hope people enjoyed that. Thank you very much. I will